Palliative care is a field of medicine which emphasizes physical, emotional, and spiritual comfort and support for patients and their families coping with serious illness.
The intent of this specialized medical care is not necessarily to cure the underlying illness, but to focus on improving the quality of life for both the patient and family.
A palliative care medicine specialist will provide some answers to the most common questions she receives from patients and families on this week's Health Talk.
So stay tuned for an important and informative show.
Health Talk is coming up next. Hello, I'm Dr. Eric Mazer.
And I'm Dr. Andrea Peterson. Today we're going to talk about palliative care with Dr. Heather Sung. Dr. Sung is the clinical leader of palliative care at Norwalk Hospital.
Thanks for joining us, Heather.
Welcome.
And we actually have two experts in palliative care on the set. Heather is the head of palliative care at Norwalk Hospital. And Andrea, you did some work in hospice as the medical director there, didn't you?
I have.
So, and I know this has been an interest of yours. So I'll sit back quietly while the two of you talk about palliative care and hospice. So what's palliative care?
So that's a great question because there's so much behind that question. One is I don't think people fully understand it, and therefore patients are not getting the full value of what it can offer. But it's not just not well understood amongst the general population, but within the clinicians as well. Palliative care is care provided by a multidisciplinary team that focuses first on the individual, what is important to them for quality of life, and helps them to define the choices that they may make in their future that aligns their quality of life with the goals of care. And it is to also relieve symptoms of suffering, so whether it be physical, emotional, or spiritual symptoms of distress.
And this has been a rapidly growing kind of medical endeavor and field, hasn't it?
Yes, it has. Rapid growth over the past several years. When I started, it was probably about 4 years ago, it wasn't necessary to do a fellowship, but now there is fellowship training for this specialty, often can be done in combination with a geriatric fellowship.
Maybe you could explain for our viewers at home what that means to do a fellowship.
Yeah, so fellowship is an extra level of training after you complete your general residency. So for me, I did a residency in internal medicine, and then you go on to do a subspecialty training. And
how many years is the palliative care fellowship?
Just 1 year, but if you
that's added on to 3 years of internal medicine fellowship.
Yeah.
So it's quite a bit, and that's actually 4 years after 4 years of medical school. So a lot of people don't realize how much training goes into preparing a Dr. Sung.
But I think that the interesting thing is that palliative care, in my belief, is really not something that is so different than what a physician should have within their knowledge base. But I think that medicine has evolved so much, and there's been so much increase in technology, in medications and research, and the pace of care has increased, and there's also been such an increase in the aging population.
And that's why you said you work in collaboration. So, as an oncologist, I often trying to treat an illness, but often dealt with the symptoms of the illness. But it would have been nice to have a partner who is expert in those symptoms, sort of helping me along the way, and that's really what's happening now. Isn't it?
And it's not just, again, I want to emphasize not just the physician, but the support comes from a multidisciplinary team. So in our team at Norwalk, we have a social worker, we have a nurse practitioner, and we have a chaplain. So, to address all those aspects of distress and support that a patient may need.
And you can also, I understand, pull in other disciplines if that's appropriate for that particular patient. So you may collaborate with physical therapy or occupational therapy, make recommendations about other things that may help patients with their symptoms.
Absolutely, and I think that in all of the rehab team is very important to us. So we work so closely with them because the functional status, one, defines the frailty of an individual, But two, the functional status and the limitations are so important to an individual in terms of what's quality of life for them.
Now, Heather, people probably heard more about hospice, and we're going to talk about that another time. But hospice is for dying patients. Palliative care is not necessarily for dying patients. It's a much broader approach. Is this, maybe you can explain, not necessarily the difference, but how is that breadth of palliative care applied clinically?
So I think you have to think of palliative care as a continuum of care, and it can occur at the start of diagnosis, often with someone who has complex medical condition. But it's the disease or their condition is typically progressive, and so a palliative care team may follow a patient from the start of diagnosis all the way through their condition, and as it progresses, their choices and their goals may change, and we're there to support them through that. Hospice is care that's focused at the end stages of disease, and that care is shifted not to focus on curative approaches, but to focus on symptom management at the late stages of disease.
But palliative care can be involved in any stage, and so even if someone's intent fully is to be cured from something, if it is a potentially curable condition, a palliative care physician may still be involved to help with symptoms.
Yes.
That's important, I think, for our viewers to know and understand.
Can you give us some examples of patients that are not necessarily cancer patients that you get involved with? Or any stories that are sort of relevant?
Because I think that's so important too when we talk about palliative care and hospice, but it's not just about cancer. It's about lots of people.
You can be disabled with pain from something. You can be disabled but with shortness of breath that interferes with your lifestyle. You can be terribly depressed and have rheumatoid arthritis.
That's
and I would think anything like that is open for intervention.
That's a great point, because I think that as this specialty is growing, we're finding that the different subspecialties are starting to recognize the value. The first group of physician specialists that probably embraced palliative care were the oncologists, but we're seeing pulmonologists are finding there's great value in collaborating with us for their patients with chronic lung disease who suffer from symptoms of shortness of breath and how it affects their quality of life and their functional status. Cardiac patients who have chronic congestive heart failure. And we actually are finding that palliative care is entering into areas that you would never have envisioned in the past, which were so focused on curatives, such as the intensive care unit. We are seeing patients there now, and in the emergency room.
Actually, we're learning a lot about managing people in the intensive care unit to improve their psychological and physical outcome beyond the disease. I mean, things like less sedation and getting them out of bed early. It's really been striking to see how different the ICU patients is cared for today compared to 20 years ago.
Yeah, and oftentimes the ICU patients, the patient, him or herself, may not be able to engage because of their illness, but we're there to provide support to the family, the loved ones, and help them through the decision-making process, because there are so many choices that can be made, and I think sometimes patients don't realize, or the loved ones don't realize, that there's choices that they can make. As physicians, we sometimes we forget to offer that there are choices and ask what's important to the individual, and so we're there as a reminder that those things can happen and that you can have some control when life seems otherwise so out of control. You asked for examples, so I think the striking example more recently that has been occurring is that surgeons are finding that palliative care can be helpful, and we've been involved more with the neurosurgical patients, so patients who come in with intracranial bleeds, or traumatic brain injury.
So there's people with significant neurologic deficits.
Where there's a sudden change in their life. And what does that future look like for them, and how do they navigate through that and the choices
and
that
their
they
family,
make?
as you
That's
said.
right. Yeah.
Yeah, I hadn't thought about that.
Yeah.
What a profound discontinuity in one's life, and what tremendous adjustments must need to be made.
Yeah.
And often conversations like you're talking about require time and patience, and by patience I mean patience on the patient's part and the family's part, and it's a process.
And really
isn't it?
getting to know the family, because
Yes.
this sounds like a very I hate to use the cliche, patient-centric. It really requires you to know the patient to help implement their wishes.
Yes. And I think that's what I find so rewarding about this specialty, because I find that, and I've said this in other talks before, but going into medicine, there are three parts of being a doctor in my mind, and one is sort of being like a carpenter, using your tools to try to fix a problem. The other is being an investigator, taking the clues and trying to find the solutions. And but lastly is the human aspect of medicine, and recognizing that person who's very vulnerable and often feeling isolated because of their illness, seeing their strength and their courage, knowing who they are as a person, and trying to support them. And that's just the joy and the gift of this specialty, I feel.
And again, do patients necessarily get better? Do you ever, is this often sometimes a transient intervention and then patients improve and they don't need that care anymore?
Absolutely. So sometimes patients do better. So while we often see patients who have complex medical conditions that are progressive, they sometimes stabilize, and they may not need you as much at that point. But our hope is to be able to provide a continuity for patients, because I think these days a lot of times patients feel like they're fragmented, and they see one doctor for their heart, one doctor for their lung, one doctor for their kidney, and so we can sort of be, as the primary care physician, a continuity for them.
And looking at them, their
As a
whole
whole
picture,
person.
as a whole person, and a family unit, if you will.
Yeah.
Now that we
Because
have about a
serious
minute
illness.
left, but how about chronic pain? Is that something that you focus on, or is that a different set of physicians?
Yeah, pain management is complicated. I know we have a limited time. We address pain in patients who have complex medical conditions. So we don't see patients who just have pain alone, but
chronic
patients
back
who have
pain or like
elderly patients who have pain, who may have side effects from medications, how to manage it, what are the choices, who have lung disease where medications may cause side effects, but not pain management alone.
Well, that's all we have time for today. We want to thank our
you
guest,
so
Dr.
much.
Heather
You're
Sung.
welcome. Thank you
It's
very
great having
much.
you on the show. A very important
Absolutely.
specialty that I think really is filling back in some of the holes that modern medicine has created.
So we'd very much like to thank Dr. Heather Sung for joining us on Health Talk today.
And please send your comments and questions to us at healthtalk@wchn.org. Andrew and I would love to hear from you.
Thanks so much for watching.
See you next time.